Good evening, everyone, and welcome to EPA's Meet the Fellow webinar series. I'm Dr. Peter Laskarides, president of the Eastern Pain Association. It's a huge honor for me to be here hosting this exciting discussion. First and foremost, I'd like to take a moment to express our heartfelt gratitude to Boston Scientific for their invaluable support in making this production possible. Before we lead off, I want to leave the stage to Neon, who will be providing a presentation. Next slide, please.
Well, thank you, Dr. Laskarides, and thank you to the Eastern Pain Association as well. So my name is Neil Ladapo with Boston Scientific. So here at Boston Scientific, we have innovative therapies that are all backed by extensive evidence, including spinal cord stimulation, the Vertiflex procedure, and RFAs. Next slide. I'm just going to be taking a few minutes to kind of go over all of these briefly. Spinal cord therapy is an advanced technology that sends pulsed electrical signals to the spinal cord to control chronic pain. There are numerous therapies available, including some that are paresthesia-based and some that are paresthesia-independent. Spinal cord therapy has been in use for over 40 years, has helped thousands of patients, predominantly with neuropathic pain. There is a trial process where the patients get to try the system to make sure that it works for their pain. And then the second step is for those patients to be implanted. Next slide. There are numerous associated conditions and etiologies: post-laminectomy syndrome, failed back surgeries, radiculopathies, postherpetic neuralgia. What you'll notice is the main highlight is neuropathic pain. Next slide. With Boston Scientific, we have our WaveWriter Alpha SCS system, which includes 4 IPGs. There are 16 and 32 contact options. There are both rechargeable and non-rechargeable that are full body MRI compatible. Our latest therapies are also available on these systems as well. Next slide. These therapies include the Illumina 3D, which separated us and allows us to control the current within 1% increments, which allows us to have a full-bodied capturing of the patient's pain profile. We also have the ability to provide combination therapy where we can have paresthesia and non-paresthesia-based therapies running at the same time. We also have our contour therapy, which is a broad field that is energy use effective. We can also provide microburst and most recently FAST, which is our subperception therapy that works immediately and provides profound pain relief. Next slide. Also in this combination of our therapies, we have the Vertiflex procedure. So the Vertiflex procedure is for those patients with neurogenic intermittent claudication secondary to LSS. So basically, the superion blocks spinal extension, which reduces or eliminates the compression of nerves at the implanted levels. It requires no resection of the anatomical structures, maintains sagittal balance, has a near immediate recovery time, and is backed by clinical efficacy over 5 years. Next slide. Most of these patients that present with the quote unquote shopping cart sign, where they are leaning forward while walking or to ambulate, because this gives them comfort and relieves some of those symptoms, where extension exacerbates these symptoms, namely the pain, the tingling, and the weakness in the legs. Next slide. As mentioned before, the Vertiflex procedure is supported by 5-year level 1 evidence, 66% improvement in back pain, 75% improvement in leg pain, 85% decrease in opioids, and a 90% patient satisfaction rating at 5 years. Next slide. Again, I'd like to thank you for your time. My name is Neil Ladapo. I'm the territory manager, cover Westchester and the Hudson Valley area. Listed also are some of the representatives that cover New York City and New Jersey, namely Jared, Mike, and Eric. Again, thank you for your time.
Thank you, Neon, and thanks again to Boston Scientific. I encourage all the viewers to visit their website where you'll find a wealth of educational resources. Moving on tonight, we have the privilege of being joined by a distinguished group of experts who will be sharing their insights into the world of pain medicine and fellowship. Allow me to introduce our esteemed moderators and panelists. Our first moderator for this evening is none other than Dr. Chris Garibo, the highly respected pain medicine director at New York University and past president of the Eastern Pain Association. Dr. Garibo's extensive knowledge and expertise make him an invaluable asset to this discussion. Joining us next is Dr. Daniel Pak, Associate Program Director and Director of Pain Innovations at Weill Cornell. Dr. Pak's commitment to innovative approaches and dedication to teaching fellows certainly makes him a tremendous asset to this panel as well. Finally, we have Dr. Cameron Marshall, the esteemed Pain Medicine Fellowship Director at New York Medical College. Dr. Marshall's passion for education and patient care has established him as a prominent leader in the field. Now let's meet our panelists, if you can all turn your videos on. Representing some of the region's most prominent fellowship programs, we have Dr. Nitish Agarwal, representing the Northwell Zucker School of Medicine Pain Fellowship. Dr. Shahryar Ahmad, representing NYU's Multidisciplinary Pain Fellowship. Our next panelist, Dr. Ankur Patel, representing the Weill Cornell Pain Fellowship. And last but not least, Dr. Prachi Patel, representing the Brigham and Women's Pain Fellowship. Tonight's discussion will cover a range of topics, offering great insights from our panelists. For aspiring residents, the incoming pain fellows who are tuning in this evening, we'll explore the process of aligning for success during fellowship, discussing academics and the evolving perspectives on treating pain, as well as board prep, job search, and postgraduate plans. With the rich agenda, we'll be sure to gain unique insights and perspectives from our panelists, speaking on their respective programs and experiences. Before we begin, I want to also mention that the EPA will be hosting a webinar on June 14th titled Transforming Your Practice Using Digital Health. Our keynote speaker, Rachel Trauman from Upside Health, will undoubtedly provide a rich discussion. Be sure to mark your calendars and keep your phone handy. I believe there's a QR link that if you scan with your cell phone, it'll allow you to register immediately. Anyway, long enough for the wait, let's dive in. Dr. Marshall, the floor is yours to kick us off.
Thank you, and thanks for having me. So I wanted to direct this first question of a series of questions about preparing for fellowship and to apply for fellowship to Dr. Agarwal. And basically, when did you know that you wanted to pursue a pain medicine fellowship?
I actually didn't know until later in my CA2 year or PGY3 year. I was an anesthesia resident, and I was initially interested in cardiac anesthesia. And then, I actually had the privilege of rotating at the end of CA1 year. And I really liked that. I really liked the procedure aspect, but then also getting to talk to the patients. And so I kind of knew a little later. I didn't know earlier in my residency training.
Okay. And did anyone have different experiences on the panel?
Yeah, I can comment. Am I being heard?
Yes.
Am I being heard? Yeah, great. So when I went through my pain rotation during my anesthesia residency, one thing, I was about to go into urology before anesthesiology because I like the short procedures that were part of urology, although they do have longer procedures. And ultimately, I decided on anesthesia, and I really enjoyed the interventional aspect of it in the perioperative setting. I really enjoyed post-op pain management and that really great gratification you get from acute pain control. I mean, somebody's going through great stress is probably one of the greatest stresses that a human goes through, especially if they undergo major surgery. And here they are barely getting any opioids. So I kind of wondered to myself, well, how can that be translated into the more outpatient setting? So I really look forward to my pain rotation. And it pretty much deserved its weight in that it was a big deal. Although back then people kind of looked down on it. Oh, you're not a real anesthesiologist. You're not a real doctor. All you're going to do is writing opioids. It kind of had this, musculoskeletal and neurological component to it, and a lot of brief procedures associated with it. There was neuromodulation around back then as well. and it made a big difference in people's lives. So I sort of transitioned, therefore, from the acute context to the chronic context by doing a pain fellowship.
Thanks, Dr. Grivo. It certainly does make a big difference in people's lives. The next question I'd like to ask of Dr. Ahmad, having gone through the process of applying, what do you see as some important factors to focus on to, as you strengthen your contention for a pain fellowship?
Hi, good evening, everybody. So just to clarify, the question is essentially like how to strengthen or bolster your application for a pain fellowship, or at least that's my interpretation. So I would say, regardless of what residency you do, it's important to demonstrate an understanding of the field of pain medicine before you apply into it. This can come more so from doing a clinical rotation that covers, the procedural aspect, but as well as the clinical aspect, and trying to make note of key patient encounters that you felt were really significant. And like for me, there was for example, there was a patient who tried, who had essentially his hand was chopped off after an injury, and it was surgically reattached. He went through all the specialists, had all the treatments, all the therapies, and then had this horrible pain that was still continuing for quite some time. He underwent an intervention by one of our pain doctors. It was a stellate ganglion block for CRPS, and he had total resolution of his pain. That was a point for me that helped me see that we really are almost at the end of the line for a lot of patients, and we have the ability to provide treatment that not a lot of other people can. And I think once you realize that, there's an incredible power that a pain doctor has. So knowing that, what value a pain doctor can provide, and more importantly, I feel like there's an importance to demonstrate that interest, which can be through research. You can present at some conferences, do a poster presentation, try to publish a case report, write an abstract. I would say those would be my recommendations, in addition to trying to do well on your in-training exams.
Certainly seems reasonable, and I think exposure to pain is extremely important. Something that, at least from the anesthesia side, seems to diminish a little bit with each new set of guidelines on residency. With that, I'd like to pass the baton over to Dr. Pack for the next set of questions.
Marshall. So again, it's really great to be here. Now that we've talked about how to prepare for fellowship, some of the meat of like why you chose the program that you did. And this one I'd like to hear from all the panelists. Why don't we start with Dr. Patel, who's over at our program at the Tri-Institutional Fellowship at Cornell. So why did you choose Cornell?
Thanks, Dr. Pak, for the question, and thank you again for having me today. I think that when I was kind of looking at different programs and going through the interview process, kind of big things that kind of really stood out to me is that pain fellowship is just 1 year. And within that 1 year, it's just a small amount of time compared to your overall training to really gain like a grasp on like all the interventions, the pathology, and get a good breadth of like procedures and experience throughout that 1 year. So one of the big things was kind of doing diverse training. So being able to kind of be at a program that kind of gives you like a breadth of procedures, different pathology. Our institution specifically, like we get to rotate at 3 different places, Sloan Kettering, Cornell, as well as HSS. So kind of being at different like environments and different settings kind of was nice because I got to see how pain is practiced through different providers, different pathologies that you see in cancer population versus non-cancer population. So those are kind of different factors I really wanted to look at. That diverse training was one of the big factors just because it's gonna be 1 year. And given that, I think mentorship was a big aspect. For me, like mentorship has been like a core component throughout my training. And I feel like even though you have that 1 year, you want to kind of take that 1 year in fellowship and kind of develop the mentorships with your faculty, and as well as just kind of build that relationship so that as you kind of build on your career, you have that foundation, you can kind of really talk to your mentors and kind of bounce cases off of one another and just kind of really continue to grow. So I think the diverse training and the mentorship were 2 big aspects I was looking at different when I was interviewing at programs. And for me at Cornell really kind of stood out when I was looking at programs and interviewing.
Yeah, I think that's a really good point. The mentorship aspect is certainly something that I stress a lot too, having access to those people, because as you pointed out, fellowship's only a year long. Certainly you get the meat of your training during that time, but you know, the learning doesn't stop. So I still continue to communicate with the mentors that I had during fellowship, and was one of the reasons why I decided actually to join faculty here when I came back from my fellowship. So those are all great points. Now, with that, I'm going to pass it over then to Dr. Prachi Patel, who's over at the Brigham and Women's. Why did you choose the Brigham?
I think a lot of the same reasons, definitely mentorship. I wanted to see as much as I could during fellowship. It's only a year, so I wanted to maximize what I saw in terms of pathology, in terms of number of patients, various anatomy, complications, just be exposed to as much as I could during that 1 year. Particular at the Brigham, I felt like I would get, or I've gotten good training in terms of the range of interventions that we can do as pain physicians. I've gotten good experience in medication management, good exposure to multidisciplinary care. And those were the things that I was looking for. And then ultimately, it just kind of came down to my time interviewing with faculty and talking to them, and felt like these are people that I'd want to work with.
Yeah, also really good points. You know, it's only a year, but at the same time, you want to make sure that it's a good fit from a culture standpoint, and also that you'll get along with the people that you work with. Dr. Agarwal?
So I think the first thing I would say is apply really broadly. That's what I did. There were a lot of things I didn't know about until I interviewed with people across the country. And then in terms of the programs, I really wanted a lot of procedures, just getting repetitions in. And so that's why one of the strong points was the Spine and Pain Institute of New York, or the Northwell program. And then the other thing was getting, I guess, experience with dorsal root ganglion stimulation. And again, I didn't know anything about it until I started, or I was on my interview trails. I think going back to it about choosing a fellowship, I think going to different conferences, if there's time during residency, just to learn, not even to network, I think that's really helpful to just to see what's out there.
Yeah, now that most, you know, I think as we're continuing to just do Zoom interviews, you have the opportunity to explore a lot of different fellowships and meet a lot of different programs without having to have the stress of traveling and go cross country. So those are also good points about applying broadly and trying to learn as much as you can during the interview seasons. So certainly I encourage everyone to do that. And Dr. Ahmad, who's over at NYU.
Hi, everyone. Yeah, so, you know, in the additional reasons, you know, for the purpose of time, I agree with all my colleagues for the reasons that they chose. I had those reasons as well, but additionally, location was also important to me. I think New York City is one of the greatest cities in the world. So if you have the opportunity to train in an area like this, to live in an area like this, you know, while you're young and you don't have joint pain, it's definitely something to take advantage of. And the second thing was, I felt that, you know, coming from an anesthesia residency where I had a very large exposure to pain management, like we did probably like 200-300 injections each, like at our residency. I already had exposure to procedures fairly early on. So when I was looking at fellowship, I wanted a multidisciplinary fellowship that would make me an expert consultant, that would be able to take on patients who, you know, I would be comfortable dealing with difficult patients, supposedly patients who had complaints that you know, weren't necessarily treated with other doctors. So the one good thing about NYU is we have a lot of specialists who specialize in certain areas of pain, such as pelvic pain, orofacial pain, you know, the spine, joint pain, etc. And then we get to work in many different types of environments, such as the Veteran Affairs Hospital, Brooklyn, you know, and all the different sites at NYU, which include the inpatient, ambulatory, as well as the outpatient settings. Yes, it could be a little bit challenging to get used to all these different types of attendings, but I feel that, you know, having the broad exposure to all these different environments really helped expose me to every type of patient that I can encounter. even some children who were treated, which I was not expecting to see, but I'm happy that I was able to take care of them. So I think for me, just to summarize, location, having a place where I truly had a multidisciplinary exposure to different types of patients. And the last thing, which is, I feel like sometimes an understated point, if you're coming from, I believe, in anesthesia or PM&R residency, oftentimes you have to take board exams during fellowship. So it's important that you try to find a program where you can have some type of balance, or a program that allows you to have time to study for those boards. And I think NYU did a really good job at helping me do that.
Great, thank you. I agree. New York is a great place to live. So if you ever have an opportunity to do that, I would encourage you to do so, whether you do fellowship or not. The next question I'm going to ask is to Dr. Patel. Dr. Ankur Patel. What's the learning curve been like during your training so far this year? And have there been any unforeseen challenges since you started and now finishing, I guess?
Yeah, I think that like especially kind of early on, coming right from like residency to fellowship, and that first kind of like month, you're really studying for boards. So like the learning curve, you're kind of coming from like the residency mindset where you may have like someone who's like a little bit ahead of you, like a senior, like a resident. But fellowship, like you kind of really, my goal was to kind of really treat it that like, hey, this is like my last year of training. I have my attending there if I really kind of want to be prepared, kind of have everything ready. I think the learning curve came to the point where I just wanted to kind of come up with the system. So in the beginning, kind of really find if you're like on our how our schedule is that you're either on procedures or in clinic. So like kind of chart reading everyone, looking at your anatomy, looking at your MRIs and your imaging, kind of be very prepared before you even come in to the clinic or the procedure suite the next day. And I think kind of early on, it was really that learning curve is more from my background as PM&R. So I felt very comfortable in terms of clinic, in terms of doing physical exam, more in terms of like some of the more like nuances in like medications or in terms of like interventions was kind of an area where in the beginning kind of like struggled, but I was able to kind of have my attendings who were able to kind of like show me different procedures that I've not been exposed to during residency, especially more advanced therapies, and kind of be able to kind of build on that. And as I kind of felt kind of more comfortable towards midpoint, it's kind of come down to the point where you really want to ask that feedback from your attendings and see where are you, how are you doing, and how can you really prepare. Like this 1 year is kind of your last year in training to kind of get as much as you can while you have an attending there to kind of help support you throughout the process. And kind of as we're at the last 6 weeks, I was actually with my co-fellows last year, and we were all talking, we're like, kind of where we started to where we are now, we all feel very comfortable in the sense that like we feel like we've seen a lot and we've done a lot, but this is kind of just a starting point where once we kind of go out as intending, it's going to be another learning curve where we're on our own, but really have those like mentors and the faculty with you that you're able to ask those questions. So I think the challenge initially was kind of like everyone said, study for boards, kind of getting the routine, get everything set up, and then just keep challenging yourself throughout the year. Don't kind of just make clinic easy, like try to see an extra patient, do an extra procedure, kind of think outside the box on how you can help your patient. That kind of keeps you motivated throughout the year and kind of help you grow as you're progressing through fellowship year.
Yeah, no, I think those are all great points. And as faculty, you definitely see where the fellows are in terms of their mindset throughout the year, because in the beginning of the year, the questions are more regarding how you do this procedure, why are you doing it that way? And now they're asking about stuff like billing, what are you billing? What's the criteria in terms of documentation, et cetera. So that's also signs of progression, but I agree with everything that you've said. And with that, I'm going to hand over the mic over to Dr. Garibo to ask the next set of questions.
Sure. So I guess I'm covering success during fellowship. Is that true, Peter? Or daily routine during fellowship?
I think the daily routine during fellowship.
Oh, I'm sorry. Okay, great. Okay, so as far as the daily routine during fellowship, I guess I'd like to ask the question, just generally speaking, on how we should divide the daily routine, because I mean there are different components to pain medicine. There's the diagnostic medical aspect, there is the non-interventional treatment aspect, and there is the interventional aspect. And then there's also the aspect of just really connecting with the patient and understanding the biopsychosocial aspect and being able to differentiate between simple pain and complex pain. So I think what I'd like to pose here is probably to the faculty, how can we craft a a fellowship where all those significant components, the medical component and the diagnostic component and the non-interventional and interventional component and the chronic pain syndrome component into 1 year, so that the fellows get a good comprehensive training. And I guess we can start with the attendings, and maybe the fellows can comment on how what the attendings have stated. So I guess any thoughts? We can start with Dr. Laskarides. Any thoughts on that?
Well, I think speaking for myself, the treatment approach certainly evolves over time, and patient to patient, getting to know the patient first, I think on a bit of a personal level is something that resonates with me, who they are, what their goals are, getting a little bit of a sense of where they stand and what their preferences are, and tailoring your approach to honor those. Also, obviously, in diagnosing whatever it may be, explaining that to the patients, I feel is very rewarding for them. And I think that's something that's imperative, something that was stressed in my training. So in a nutshell, that's that. And then moving forward, I try to incorporate the classic multimodal approach, opiate sparing if possible, and that's choose an intervention when I can.
Yeah. Dr. Marshall?
Thanks. We're actually thinking about this a lot now as we design our curriculum. I think one of the main things that we are focusing on in designing the curriculum is getting experts on board in each of the particular fields that pain draws from and that pain fellowships rotate through, probably including some extras beyond psychiatry, physiatry, neurology, etc. We're focusing a lot on other rotations like neurosurgery, radiology. I think it gives fellows a chance to do a lot of learning and a lot of thinking about approaching the patient from different perspectives, from a surgical perspective, from a diagnostics perspective. And then beyond that, we're really trying to focus on just an enormous amount of exposure. I think I don't think anyone wants to do a second year of fellowship. Everyone's pretty much ready to go, but there is a bit of a tragedy that it's only 1 year to learn something that for a lot of people is very new. People have various exposure to pain in their residency, and it varies broadly. And so I think for us, having a broad patient exposure, including a generous amount of pediatrics on the inpatient side, cancer patients, end-of-life care, people will have the chance to find niches that they really enjoy. A bit of interventional radiology mixed in there for the, in addition to the pain procedures. I think people will get a lot of good exposure and kind of figure out which direction they want to take their career. And then finally, I think in developing a day-to-day routine, it's important to kind of add some extras in the curriculum, whether it's participating in ethics committees or things like that, so that you can kind of see the full aspect of what goes into a hospital and what goes into taking care of some of the patients.
Yeah, thank you, Dr. Marshall. So that's really a key part, because in understanding what pain medicine is developing into, we become integrated into care of essentially humankind, given pain is such a common condition, and we become primary care providers for acute and chronic pain in many respects. And our fellows need to figure out which arm of pain medicine they're going to go into, whether if it's acute pain whether if it's palliative care. We took an ER resident last year. Some of them may go to the ER, and that was all in an effort to opioid spare. There's an administrative aspect to it with respect to compliance, JCO, Department of Health, and so on. And then there's also the complex pain syndrome patients that we got to get. So Dr. Pak, with respect to, let's start with the complex pain, given this is an interdisciplinary specialty. How can we develop a daily routine for our fellows so that they're able to, sort out the complex pain and sort of call it where this patient needs some type of an interdisciplinary discussion? What does your program provide, or what's the optimal setting to discuss such patients in a interdisciplinary setting that we can integrate into the fellow's day?
Yeah, I mean, there's a few ways we have tried to make ours as multidisciplinary as possible, and one of which is, certainly we start with our didactics. So we have a good didactic series that we do twice a week. These are fellow and attending led. We try to have a variety of different types of, not only physicians, but we try to draw on the wealth of resources we have from other specialties. So whether that's physiatry, neurology, radiology, spine surgery, orthopedic surgery, our rehab colleagues. And so we try to incorporate as many people as possible into our curriculum. That not only includes the didactic portion, but also from just kind of an experience standpoint. So having them work with these people. And I think we have a kind of a wealth of resources because we do draw on 3 different hospitals. So our fellows trying to rotate through all these different institutions. The other aspect then is how do you get them involved when it comes to like a single patient or direct patient care? And we do have other types of multidisciplinary conferences that we actually engage in. So one thing that we do, and we work specifically at Cornell out of the spine center. And so for example, every Wednesday, we do a multidisciplinary spine conference, which is very similar to what you would see in like a tumor board, for example. So usually the people who log into this is always a neuroradiologist. We have rehab doctors, we have neurology, we have pain medicine, we have interventional spine from the rehab standpoint. And basically we present cases and talk through these cases. A lot of times they tend to be more tertiary level cases and questions that we ask in terms of what would you offer this patient, what do you think is going on. One other thing I didn't mention was we also have a pain psychologist who joins in. And so really it's an opportunity for us to discuss difficult cases, to examine every element of their pain syndrome. And I think discussions like this give our fellows and a lot of our trainees a really broad and very deep exposure to the complexity of different types of chronic pain syndromes. This is mostly from a Cornell standpoint, more of a interdisciplinary spine conference, but I think can also run the gamut of sports medicine, et cetera. So those are the ways we try to get our fellows involved, and I think that they have found that to be pretty rewarding.
Yeah, thank you, Dr. Pak. That's great. I mean, I think the best advice that we can give to all the fellows and future pain medicine specialists on the line is pretty much what Dr. Marshall and Lascaridis and Pak have stated. You sort of got to be able to sort out the pain and differentiate between the simple pain that just needs an injection versus the more complex pain that requires an interdisciplinary discussion, like the tumor board that Dr. Pak brought up. The last question I have 2 main topics, and I think I'm just going to open them to the panel in general. One of them is that given pain is really evolving, what we're finding is that in academic centers they're really sort of becoming their own departments, and they're of great utility in terms of, for example, perioperative analgesic pathways, sickle cell management pathways, pain steering committees is, for example, something that we have at NYU. We have a pain safety committee. And we pretty much, come up with policy and procedure that's system-wide. At some point, and there have been such departments formed across the country where somebody may be a chair of pain medicine, for example, and that has happened in the past. What are we doing to develop future leaders in pain medicine, not just from a clinical perspective, and certainly that's extremely important, but also from a advocacy perspective, as well as from an administrative perspective, so that pain can become a more distinct specialty than it already is? Are we training our fellows in that direction, in the administrative direction?
Yeah, I'd like to jump in on this, Dr. Gribo. I think there's been a few instances throughout this year where I became more cognizant of the multidisciplinary nature of pain. And it kind of brings a larger question as to what responsibility we have. Like one example is at NYU, we've had multiple patients who are awaiting heart transplant or who have electrical storms such as ventricular tachycardia, for whom we've been consulted on to do a stellate ganglion block, for example. And these patients have had great degrees of success. The Veteran Affairs Hospital where I work, there's a lot of patients with PTSD who the psychiatrists ask for our help for a stellate ganglion block. I mean, this is just one intervention, but my question is for the panel, is do we have a responsibility to be going to, cardiology conferences or psychiatry conferences and representing, ourselves as pain doctors and, showing what else we can really offer?
I'll take this one. I mean, certainly we have tried to do that from the standpoint of kind of, I think the category of pain medicine is kind of this this silo specialty where people have the understanding that it's just pain medications. And I think obviously our specialty has developed a lot more than just writing medications, right? So so one thing that we've tried to do is really go to a lot of the other specialties within the hospital to inform them and educate them on the things that we can offer. One such thing is, you mentioned stellate ganglion block, and there's a lot of off-label uses for stellate ganglion blocks, right? So obviously CRPS is probably the most common one that we use in the pain clinic setting. However, if you look at what we use it for now, there's a lot of other things. So not only PTSD, but there's some evidence to suggest that it might be useful for long COVID syndrome. So those are, has been one kind of referral pathway for us. Also, we've been now involved with the neuro ICU, for example, where they've asked for stellate ganglion blocks for patients with subarachnoid hemorrhages who have these kind of persistent vasospasms. Right now, these are kind of all off-label uses for this particular block, and this is just one example. But certainly, our sphere of influence can extend beyond just kind of the outpatient clinic setting. I think it helps to be able to educate other specialties on the things that we could potentially offer, and certainly we have tried to do so here. But I know a lot of my other colleagues have been doing the same at their respective institutions.
Any other colleagues?
Yeah, I'll add to that. I think I'm always surprised at what primary care doctors, et cetera, know about what we do in pain management. I agree with Dr. Pack. It's often it doesn't seem to extend often beyond medication management, and just a little bit of education and showing up to someone's either clinic or grand rounds and going over some stuff can really, I think, lead to much better patient outcomes, because suddenly you'll get referrals for conditions that providers never knew there was treatment for. I think both the colleagues I work with gave grand rounds today in different departments to educate them on some of the things that we can offer. So I think getting your foot in the door with different departments, I don't think you need to go to every conference they have, but getting your foot in the door with different departments can certainly be beneficial for both your practice and for patients.
I think just to add from a fellow's perspective, a lot of times we have an inpatient service, and a lot of us kind of spend a couple months on that service, especially when we're at Sloan Kettering during that rotation. I think that's kind of when you have that direct communication with your primary teams on an inpatient setting. So it allows for that communication to be very constant. So all the time we'll get consulted for different blocks, different procedures, different medications. And this is kind of from a fellow's perspective, when we actually take the time and do some education to the primary team, to the oncology team, to the primary hospitals team about the indications in terms of what the platelet should be, what the coagulopathy labs what we need, what the procedure entails. So it kind of allows us to have those I guess mini conversations with teams. And over the time, we've actually seen teams that are actually consulting more for adequate procedures or more appropriate procedures, and kind of how we can kind of work together and kind of have a collaborative pain conference and talk about more advanced, complex patients and how we can help them. And I think that from a fellow's perspective, when you have the opportunity to kind of work with my colleagues in different departments. I think just to really take an opportunity for that, like especially on an inpatient service, you can kind of really talk with them and educate them. A lot of your colleagues, I mean, I know a lot of my medicine friends, they don't know like some of the procedures that we do, and just taking 5 minutes and talking about like what an epidural is and like what a DRG stimulator is. Those kind of things kind of really go a long way in terms of when they're thinking about those things for patients.
I'll also chime in. I think from the private practice standpoint, the way I see pain field is more of like a disruptive specialty, almost like Christensen's disruptive innovation, where we're doing all these minimally invasive procedures where it's about the customer or the patient and their quality and what is their quality of life after these procedures, as opposed to a 2 or 3 level fusion or one of these bigger procedures. And so I think there's also a interest, or there's also a avenue for the pain field to develop into that arena.
Yeah, I just want to highlight that. I mean, some very good points are being brought up. We really tie a lot of the systems in a academic medical center together. So we have a huge leadership opportunity, and that ranges from length of stay, patient satisfaction, opioid reduction perioperatively, post-discharge patient satisfaction, compliance, and I think we can really play huge roles in your future careers after your fellowship. I think we do graduate a lot of colleagues that go into private practice, and then that's certainly fine. But there's this whole another arm of pain medicine that you can also consider for your future as well, as a clinician and as an administrator. I guess I'll pass it on to the next topic.
Sure, I can take over. So for the next topic, we'll talk about academics and fellowship. The first question I wanted to touch upon might be more for the moderators and the panelists, but is there anything unique about your program's didactic structure or procedure exposure that would be important for residents to know? And if a panelist wants to jump in as well, that's fine.
Yeah, I'll kind of talk about our structure. I mean, it's a combination of, I think didactics are what they are. We do an introductory lecture series for our fellows when they first start, and that's basically a lecture series that focuses on kind of the fundamentals of pain and pain procedures. I think that's all very helpful. I think what is more innovative now is how do we teach procedures other than just practicing on patients, right? Our patients, when we do our procedures, it's in the outpatient setting. We do it in our fluoro suite, and these patients are not sedated. So there's a limitation in terms of what we can teach in front of the patient and what we can say, right? So trying to also then offer alternative modalities of training our patients, and that specifically for our program is something like more of a simulation curriculum. And so, we specifically utilize a BioTROS cadaver, if you guys are familiar with that, but it's basically like it's a simulated spine model that also can be used under fluoroscopy to teach procedures. So we use that as a method of teaching basics of not only fluoroscopy skills like reducing dose and how to get your views, et cetera, so how to manipulate the fluoro, but also teaching procedures. And so that is something that we've instituted over the last couple of years. We have found pretty good success with it. So we do that in the beginning of the year to be able to teach fellows the very basics of spine-related procedures on this model without having to practice on patients. In addition to that, I think we've also tried to incorporate industry-sponsored assistance, whether that's, we can provide as much exposure as we can to certain procedures, but let's say some of the more advanced stuff, we do welcome assistance from them to be able to provide teaching, whether that's with a cadaver model or something along those lines. So we've held labs, for example, for vertebral augmentation, to teach our fellows not only the basics of vertebral augmentation, but also provide them with exposure to some of the newer therapies like spine jack, which you may or may not see during fellowship or have a lot of exposure. So from my standpoint, it's a combination of good didactics, providing simulation education, like what we talked about, having maybe some involvement, whether it's through societies or industry, and then also on top of that, having real life patient experience. But I find that a well-rounded curriculum involves all components of those.
Yeah, certainly fellows and residents will learn an enormous amount in a well-rounded a well-rounded curriculum. And when patients are awake, it can be somewhat of a challenge to teach and kind of take corrective action. I think at Westchester Medical Center, one of the unique things about the curriculum we're putting together is to be a little bit more narrowly focused, the interventional radiology exposure. We do a lot of procedures that you might read in kind of the older pain books, but maybe have been taken over by other fields. Disc aspirations for osteodiscitis, bone biopsies, tumor biopsies in the spine, and I think it's nice to get a little bit more exposures to putting a needle in a vertebral body or putting a needle in a disc. If you can do it for a disc aspiration, you can do it for a percutaneous disc, or doing if you can biopsy a tumor in someone's L2 vertebral body, you can the next step is a vertebroplasty or a kyphoplasty, and the next step after that is osteocool. So you can just by repetition, you can get exposure to kind of a little bit more complex procedures that people might not be quite as comfortable with coming out of fellowship. And then certainly doesn't hurt if patients are under a GA for these procedures, which they are. But yeah, I agree. Each fellowship tends to have kind of unique experiences that can set it apart in different ways. I think I've heard of places that have 4 weeks or a full block of neurosurgery rotation. Well, you're going to be very good at implants if you go there. So it's definitely something for residents to consider when they're applying to fellowships. And Dr. Grieb, did you want to add anything or?
Yeah, I think, my comment is that I think, just like you said, Dr. Marshall, I think the setting needs to be appropriate. So someplace like VA or Bellevue is a lot more appropriate than a place like the orthopedic center within the main hospital, where we may see some 40, 50 patients a day and the population is just not suitable. But I mean, just like Dr. Peck stated, I think BioTraz is really a very good way. I wish there were more similar models. The company went bankrupt, actually. They had a big fire. But yeah, I mean, I agree with Dr. Pack that really goes a long way to teaching technique in a more comfortable setting. But academically speaking, we also have 2 dedicated research colleagues with NIH funding that have about a half dozen projects that are already in progress with faculty that have papers in a variety of different stages. So certainly that this is your golden opportunity to be part of a publication and get your name out there.
Exactly. That's great. Well, one other question that I wanted to ask for the panelists, because I think it's targeted a little bit more towards fellows, is there any part of the curriculum or part of your experience now that you're at the end of your fellowship that you wish you had more of? And any of you can chime in if you think there's something you wish you had more of, or if you thought it was a perfect curriculum, you can say that too.
I'll chime in.
Perfect.
Yeah. So we got access to the BioTraz model, I think in the latter half of the year, and I think it's a phenomenal model. And I feel if we had invested in something like that earlier in the year, and maybe just had like structured didactics with like an attending like every 2-3 weeks on that would have been very helpful. We have it now, we use it fairly regularly, but I feel that if we had it earlier, the experience would have been better.
Great. All right, if no one else wants to chime in, I don't know, do you think we have time for more questions, Dr. Laskarides, or?
We have about 10 minutes. I think a great topic, perhaps at this point, networking and approach towards the job search, right? Everyone, I think one thing in particular is, the residents engage in a match getting into fellowship, right? I remember how it was for me where, you could apply for a job, midway through fellowship. I remember springtime was kind of the hot time where job openings started coming about. You may hear from one opportunity and another one just comes out of the cracks. If I may address Prachi Patel, Dr. Prachi Patel, if you can, if you kind of shed a little light on your experience so far.
Yeah, so for me, I knew I had a particular city that I wanted to go to. So my search was very targeted and I started pretty early towards the end of residency, beginning of fellowship, just reaching out to my network, attendings I knew from med school residency, and then coming into fellowship, really tapping into the network of alumni from my fellowship program helped me eventually find my job. But I know a lot of my co-fellows found opportunities or were connected to opportunities through the reps that we work with. So for me, it was more just word of mouth, and that's how I was able to find my job. But there's definitely a lot of value in using your network to find these opportunities.
Anyone else want to chime in on their experience? Anything that may be unique? Without saying
Yeah,
so.
I can add in. My situation was very similar to Dr. Patel's as well, in the sense that like I kind of knew what city and what geographic region I was really interested in. So I really did kind of lean on my faculty as well as my mentors to kind of really see what the opportunities are in that region. The reps were like actually amazing. They got me connected with the site directors in that region, kind of really reach out to kind of see what is available and kind of get a little bit lay of the land in terms of what practices are available. And actually looking for new providers. But I think the big thing was when it came down to like contracts and understanding kind of the nuances, that's when I kind of leaned on my faculty at my program in terms of understanding like a private practice model in terms of compensation versus like a straight RVU model versus academic versus salary and like a 10-year kind of track. Those were all kind of things that kind of I never really like understood or really kind of came across. Like as I think someone else in the panel said, throughout training, you're really just matched. You're kind of told where to really go every year, right? You have a kind of say you interview, you rank, at the end, it comes out to a match. Where job time is like your first time where you get to kind of pick and choose kind of where you want to go. So like really kind of understanding kind of like what city, kind of geographic region, and kind of what you want your practice to look like. And some advice that I got from like one of my mentors was that kind of really, you may not find the job that may be perfect, but find something that you'll be happy with and kind of see if you can find mentors at the same practice. If they have the same exposure to different procedures. There was some practice I looked at just did mostly kind of bread and butter versus some that had exposure to advanced therapies. In fellowship, I had opportunity to kind of learn those therapies. So I want to continue. So being able to kind of be in a setting where you can have that was very important. Then talking to the reps, talking to the local people in the area, kind of what's the reputation of the practice or the hospital setting was very important for me. But I think the big thing was contract negotiation, kind of understanding the contracts and understanding kind of the breakdown. So you know what you're getting yourself into before you start.
100%. I just remember, how new it was for me, and you have an opportunity in the contract to be something completely unique, which may be something that may be to second thoughts. So I remember that being quite it being helpful, as you guys alluded to, bringing it back to your program, having my attendings review the contract when I was in those shoes. Also considering we have, again, a significant amount of residents, and a lot of them are eager to go to these conferences, national conferences, regional conferences. You meet a lot of someone who kind of express their opinion on, what that, how that kind of led to their, or what role that played in their journey, getting into fellowship, getting into their dream job, etc. Dr. Agarwal, perhaps if you can provide some thoughts.
Sure. So initially, during residency, I didn't actually know anything about the pain field or like the conferences and stuff. I think that would have been a really good opportunity if I had known earlier. During fellowship, I attended a lot of conferences as part of the program. I applied broadly. I also used recruiters. So that's something, and they were really helpful. And you talk about different locations or different model. They're like, especially for anesthesia, there's even a hybrid model where you can do some anesthesia, some pain. So that was, different models of whatever you're looking for. There's like an opportunity with that. And then lastly, I think attending conferences it allowed me to just see what's out there and talking to different people. And people are really friendly and they're really open, not just leaders in the field, but different attendings. I met some lawyers that were in one of the conferences, so I was able to talk to him about the contracts and he was able to review that. So, just having an open mind and just trying to learn stuff during this whole year, I think that's important.
Would anyone else like to add to that?
Yeah, I'll jump in. I agree with Dr. Agarwal. I think conferences are definitely a great resource. They're oftentimes in really nice cities. You can get to do a little bit of traveling as you go there. And the other thing I feel that I didn't really appreciate the value of until the latter half of fellowship is the alumni network of your fellowship. You can talk to, your program director or whoever the attendings, your mentors are, and then just ask them, hey, do you know any graduates who practice in this location? And then they'll give you their contact information. You reach out to them. It's often like bypassing the middleman and you just go straight to the practice that you might want to be interested in. That's how I got in touch with some groups that I could have potentially explored. So I would say I think conferences are great. You can utilize resources, but also make sure you take advantage of the alumni network of the program you choose.
I would add that also get involved in your societies. I think interventional pain management is under great pressure from a reimbursement perspective. We're getting challenged across the board. Some, local coverage determinations that are being written, they're raising the bar. Perfect example of that is, for example, I think Medicare overpaid by some $30 million, and now the government is determined to get it back. And the way it's going to get it back is they're going to audit you to see if you met their documentation criteria. And if you didn't, they're going to ask for the money back for that particular visit and the procedure. And they can certainly do that. They can put a tremendous amount of pressure on you. Another example, let's say the 80% threshold for RFA. What's wrong with 50%? It was 50% for quite a long time. And all of a sudden it's 80. 50 was not good enough. So we can get quite cornered interventionally, such that it can be very difficult to document effectively, get authorization, and get paid. So join your societies. So that's Eastern Pain Association, ACIP. You really got to support the specialty at the local level and at the national level. So your state societies, EPA, and your national societies. And it's fine to go join the national society from an education perspective, but also needs to be a national society that's going to help things out from a reimbursement and from a CMS perspective as well.
Yeah, one other thing I'll say is that the best jobs aren't really advertised, right? So you oftentimes have to go and find these. I would say utilize your network. So certainly you can use your representatives and stuff like that. But it always helps to have a concentration of pain doctors in one location where you can talk and you can cast a wide net and maybe you get a few good leads. But oftentimes, let's say if you go to a conference, whether if you want to stay in New York, then I think EPA is a great place to actually get involved, right? It's a single day conference. You can talk to a lot of people and get exposure that way. It always helps to have your eyes on the ground. The national conferences are also effective, right? So you can network and speak to people. And then again, the best jobs aren't going to be the ones that you can just Google on. So sometimes you have to go and look for it.
Wholeheartedly agreed. We are at time. I want to thank everyone for taking the time to be part of this. I think it's been a great success. I think our attendees certainly got great material to move forward in their journey in a great way. Again, putting a plug for next month's webinar titled How Digital Health Can Transform Your Practice, featuring our keynote speaker, Rachel Traubman from Upside Health. If you scan the QR code, it'll link you up for registration. Once again, thank you, everyone, and have a great night.
Thank you.
Thank you.
Nice work.